Sir, third year.
Huh?
Third year,
Third
sir.
year. Ortho theory, clinical posting.
Yes, sir.
Any connection to ortho is established or not yet? How about
Came to know, sir.
not attended any ortho classes? Yadgiri, forgive me for pronouncing wrongly, but you can tell me the correct pronunciation. Hello?
So Yadgiri, sir.
Yadgiri, okay, good. Good. You are in which year?
Third year, sir.
Third year. All are in third year. So there is
Yes,
no
sir.
connection established for orthopedics still, I guess. Okay?
Yes, sir. Yes, sir.
Okay. So the objective of today's class, see, basically I have prepared for those who are in final year and who have passed final year during are in internship, who are preparing for exams. Okay. That
Okay,
is
sir.
the main objective. But then I think today's students are basically from second and third year.
Yes,
So
sir.
you need not be disappointed for having not answered the MCQs.
Okay, sir.
Try attempting, but don't be disappointed because you have not read anything in orthopedics yet. So without wasting much time, we will start. Okay.
Okay,
So
sir.
whatever you learn today, you go and read that. So there will be some reinforcement, even though
Yes,
you
sir.
appear for ortho university exams later on. Okay, we'll start.
Okay, sir.
Uh, okay. Today I'm dealing with spine injuries. Okay, spine injuries. See, most important thing now that I have to start from very basic. So spinal cord has four regions: cervical, okay, four regions: cervical, thoracic, lumbar, sacral, coccygeal. Of course, coccygeal is less. So you have C up to 7 cervical vertebra, 12 thoracic, 5 lumbar, 5 sacral. Of course, all fused to form one sacrum bone, and 4 coccygeal bones. Okay. So I was not intending to go in so much details for basics. Just because you are in second and third year, I had to explain this. Okay. So what is the outcome of injuries at different levels? You should learn this. Okay, simple. So one thing you know very well, these are vertebral column. This is a vertebral column. So inside is a spinal cord. In the what is important is generally your spinal cord ends at lower border of L1. Lower border of L1. Okay. So that means anything above lumbar, above L1, especially in thoracic and cervical injury. If it is thoracic injury, it causes paraplegia. If it is cervical injury, it causes quadriplegia. You should know one thing. It is very simple. Quadri is all four limbs. Para means two limbs. So a cervical spine injury causes quadriplegia. Please remember this. So above C4, because upper limb innervation starts from C5. C5 to T1 causes is formation of brachial plexus. You remember this? I will touch upon some anatomy. So that you will be refreshed to understand the orthopedics. So brachial plexus is formed by C5 to T1. So anything below C4, above C5, this C5 is spinal cord level. Okay. So spinal cord C5 corresponds to C4 vertebra. So there is a difference. You should know this. C4 vertebra, at that level you have C5 cord level. So any injury above C4 vertebral injury, you will have a quadriplegia. Quadriplegia or tetraplegia. So both upper limbs, both lower limbs. Okay. So up to T6. See, up to C6 also quadriplegia. Thoracic C6. One thing you remember, there is one important formula you should know this. In cervical vertebra, you to know the cervical cord level, add 1. So suppose there is a C4 vertebral injury, the level of spinal cord injury is C5. Okay, in thoracic, upper thoracic, about T6, add +2. Okay, +1 and +2. L1, L2, you will have all lumbar. So this you should know, you should go and read this. Up to L1 injury, you will have paraplegia. Whatever I am mentioning about this levels is vertebral level. You please remember that. So one thing, quadriplegia from C4 up to C6 causes quadriplegia. Both upper limbs and lower limbs are paralyzed. T6 vertebra up to T6 to L1 will cause paraplegia, means basically both lower limbs are involved. Both upper limbs involved is very rare. Both upper limbs involved and lower limbs not involved is not possible because of the spinal cord arrangement of the cord or tract arrangement. Please remember this. Okay, and also something about the anatomy of the spinal vertebral column. So I'm not going to anatomy of the spinal cord. I will explain only in this slide as anatomy of the vertebral column. So you know very well, vertebral body. This is the vertebral body. This is a sagittal section of the vertebral column. So this is a superior articular facet. Here comes your inferior articular facet. This is the lamina, and this is a spinous process. Okay, so please remember this is the bony components what I said. So the ligaments are anterior longitudinal ligament, posterior longitudinal ligament, interlaminar ligament, interspinous ligament, supraspinous ligament. See, it is all there. Supraspinous, okay, interspinous because it connects the spinous process, and ligamentum flavum is nothing but interlaminar. Interlaminar ligament is ligamentum flavum. It is called flavum because it is yellow in color. Today I was intending to for explaining more of ortho, but I'll be trying to deal more of anatomy, less of ortho. Okay. So one thing you remember, this vertebral column is by Dennis, uh, by Dennis is divided into 3 columns. Divided into 3 columns, helpful in classifying the fracture, classifying the spine fracture. Okay, so anterior column is anterior half of the body with including anterior longitudinal ligament. Middle column is posterior half of the body, vertebral body, and posterior longitudinal ligament, and beyond that is posterior column. So spine is divided into 3 column. 3 column concept is given by Dennis. And why it is important is it will help to understand the stability of the spine. Stability of the spine after the fracture. See, whole idea is the spine has to be stabilized. Otherwise, your spinal cord which comes here will get injured. The treatment management of the spine fracture depends whether the spine column is stable or not stable following the injury. Okay, so for today, you remember Dennis has classified or divided the spine into 3 columns. That's all. If you can remember, that will be great. Okay. Okay. See, one more important thing is after spinal fracture or vertebral fracture, definitely there will be involvement of spinal cord. Okay. So, spinal cord can be damaged to different extent. It can be damaged to different extent depending upon the severity of the injury. So severity can be person falling from a great height, more than 20, 30 feet from a building, or suicide attempt or accidental injury. It can be anything falling from a great height causes the spinal fracture. In India, most common cause for spinal fracture is fall from height. Please remember, this can be asked in some MCQs. Fall from height is the most common cause for spine fracture. Associated injury for the spine fracture is calcaneum fracture. So please remember, any fracture, most common fracture associated with spine fracture is calcaneum fracture. Okay, I'm deviating a little bit, but that is essential. That's how you learn from relating to each other. So spinal cord is injured to different extent. So spinal cord injury can be 3 different common types. So anterior cord syndrome, central cord syndrome, Brown-Sequard syndrome. So I will not draw the diagram of the spinal cord. This is spinal cord. So majorly posterior cord injury, where posterior part of the spinal cord is injured, you will have a posterior cord syndrome, anterior cord syndrome. If there is a central cord injury, it is a central cord syndrome. Brown-Sequard syndrome is half of the spinal cord is involved. I will explain that subsequently in one more slide. It might appear a busy slide now, but we'll come to this slide again in the end. Okay. So what is spinal shock? You have to understand, whenever a patient has a spinal fracture, a significant spinal fracture, especially when involved in fall from height, you examine the patient at the accident site or in the casualty. You will see that whether the patient is moving the limbs, upper limbs or lower limbs. If the patient is conscious, first the patient has to be conscious. And if patient is conscious, you ask him to move the upper and lower limbs. If it is not moving, if he is unable to move upper and lower limbs, you are dealing with neurological injury. It can be paraplegia or quadriplegia. Again, one difference you please understand. Plegia means complete paralysis. Complete. Paresis means partial. Paraparesis means some movements are there, some sensation is there. Paraplegia means complete absence of movement or complete absence of sensation. Okay, I will not divide that. So you examine a patient falling from a height, patient is conscious, you ask the patient to move, he is unable to move the upper and lower limbs. So in that case, the patient can be in spinal shock. If the patient is brought immediately within 48 hours, patient can be in spinal shock. So what is spinal shock? After the period after spinal cord injury, there is no reflex in this. Reflexes is completely depressed or absent. So spinal shock is absence of reflex or areflexia. No movement, no reflexes. So usually it resolves in 24 hours or starts resolving from 24 to maximum 48 hours. What is important is what is important is Once the patient comes to casualty, you examine, he is not able to move the limb. There are no reflexes, no deep tendon reflexes. So he is in spinal shock. You are admitting the patient in the ward. After 2 days, the patient might recover from the spinal shock or might not. So spinal shock ends by 48 hours. So what you have to do is you have to examine for bulbocavernous reflex. So I will explain what is bulbocavernous reflex is. You apply deep pressure on glans penis in male or clitoris in female and feel for one finger. You do PR, index finger is in the rectum anus. By applying pressure on glans penis or clitoris, if you feel the anal contraction, it is bulbocavernous reflex present. So in spinal shock, all the reflexes, superficial or deep tendon reflexes are absent. Bulbocavernous reflex, after you examine the patient again in ward after 48 hours, if it is present, means the spinal shock has disappeared. Spinal shock. So whether cord is injured completely or partially, complete paraplegia is there up to 48 hours. After 48 hours, when the spinal shock disappears, you will know whether the spinal cord injury is complete or incomplete. You have to remember this. Okay, so you do not know whether the spinal cord injury is complete or incomplete before 48 hours or 24 hours. So you have to wait for the spinal shock to disappear and then you will know whether the spinal cord injury is complete or incomplete. Am I clear? Am I clear?
Yes, sir.
Yes, sir.
Okay. I don't think has anybody left. Okay. Vandana is in which year?
So final year.
Okay, good. So I guess there is a heterogeneous group. There are second and third year people. You are done with ortho, Vandana?
No, sir. Only 1 month of postings I had.
Okay, fine. So you are all sailing in the same boat. Okay, we'll come back to this. You are you following?
Yes, sir.
Okay, good. So yeah, I am trying to have more pictures so that learning is always done by visualization or by relating. So whatever you see today, you have to imagine that picture and remember the picture, or you relate to that anything else which has happened in the past or in and around. So there are two important named fracture. Jefferson fracture and hangman's fracture. So please remember, Jefferson fracture and hangman's fracture are cervical spine fractures. So please remember, Jefferson fracture is C1. J comes first, H comes later, C1, C2. There is some mnemonic also, I am not sure. Hangman's is basically when a patient, whenever there is a convict who is hanged, he will have a C2 fracture. Hangman's fracture is H2 or C2 fracture. Jefferson fracture is C1 fracture. You have to make a note or attempt to memorize and remember this. There is no other way out. C1 is Jefferson. Okay, C2 is H2 or H2O, whatever you remember. Hangman's is C2 fracture. Jefferson is C1 fracture. So please remember, I will not go into further details because you still are in third year. You remember this C1 is atlas. C2 is axis because there is one dense. This is called as uh, this is a pivot joint. So to explain you in better, S movement happens at atlantoaxial movement. No movement happens at atlantoaxial joint. This C1, C2, atlantoaxial noding of the head side to side happens in C1, 2. So this is the axis. This is atlantoaxial joint, no movement at this pivot joint. So this will articulate with the ellipsoid of the occiput. So this is atlanto-occipital joint. Atlanto-occipital joint. This forms this movement. This joint is involved in no yes movement. Okay. C1, C2. You can see. Please remember there is an axis. So axis means the head is moving on this axis. The head is moving. This moves with the head. The skull. This moves with the skull. And it is standing on the axis here. It is like a globe standing on the axis. So no movement at C1, C2. This moves here. Yes, movement happens here. Okay. So please remember, Jefferson fracture is fracture of C1. Today, if you can remember for today's class, C1 is Jefferson, C2 is Hangman's. That is more than sufficient. Half of my purpose is achieved. Okay, C1 Hangman's again H2. So this you have to remember for next 2 years. You will never forget this. J1, that is Jefferson. H2 is Hangman's. So this is some pictorial representation I wanted to show. See, this is where is fractured, C2. And cord compression, and the patient dies a sudden death. So Hangman's is C2. Again, if you can remember, traumatic spondylolisthesis of the axis. I will explain you so that you will easily remember. So this is our axis vertebra. This is our atlas, isn't it? So what has happened? Spondylo means what? Vertebra. Listhesis means slip. It has slipped. Anterolisthesis means forward slip. Retrolisthesis means backward slip. So traumatic listhesis, spondylolisthesis of axis vertebra. Easy to remember. So the words are traumatic spondylolisthesis of axis is Hangman's fracture. Whenever a convict is hanged to death. So there is a fracture here and the spinal cord is compressed. There is a sudden respiratory arrest. I wanted to show this board, especially if you are in an emergency medical team. There is something called as emergency medical team. Generally here paramedics are there, but in disasters or mass accidents or natural disaster, if you are involved, one thing you remember, you have to immobilize the spine body of the patient with a spine board. This is a spine board. Always there are two side supports. You should not move the cervical spine because you will cause a secondary cord injury. Already if the patient is conscious, he can tell you he is moving the limbs, you will know cervical spinal injury or is there or not. But if the patient is unconscious, you have to immobilize in the spine board. So there is no abnormal vertebral spine movement to prevent further injury. This you have to remember, spine board. Okay, that I just wanted to show you. I will explain certain terms today. Only then I think it will be interesting for you instead of solving too many MCQs. So scivora is spinal cord injury without radiological abnormality. Spinal cord injury without radiological abnormality means if patient comes to you with a history of a vehicle accident or fall from height, he will have paralysis in the lower limbs and upper limbs. But when you take an X-ray, it is normal. You read a report. Generally, it is written as NRA, no radiological abnormality. Okay, spine looks normal on X-ray, but there is a paralysis of limb, lower limb or upper limb, depending upon the type of the injury. So these are called as scivora. Scivora means spinal cord injury without radiological abnormality. When it happens, this happens especially in the childhood. If the patient the child is involved in a vehicle accident, dashboard injury, suddenly the car hits someone in the head, there is a sudden flexion of the neck and extension. So the spine will be flexible in the child, just like you see facial injury in the children. Scivora is seen in spine injury of the children. This is typical of children involved in a vehicle accident where spinal cord injury. So there is a neurological injury, but radiologically normal films. This is called as scivora. So how do you detect further? You have to do either CT or MRI. MRI is always better for soft tissue injury. Please remember only two words you please remember today. CT scan is for bony elements. MRI is for soft tissue injury. Wherever, either spine or any other joints. So MRI is for soft tissue injury. CT is for skeletal or bone. Okay. So I will take some MCQs. If you are ready,
Sir, I have a doubt.
yeah, tell me.
Sir, is it same as whiplash injury?
It is a whiplash injury.
Okay, sir.
It is a whiplash injury. It is a whiplash injury, but in whiplash injury, if there is a fracture, you can. If you see a fracture here, if there is a fracture here, or if there is a dislocation, there is no alignment of the vertebral body, or there is a teardrop fracture. That it mechanism is whiplash. You understand this? Whiplash is, you know what is whip, isn't it? Whip is what you use for your bullock carts or whatever, horse or whatever. Whiplash, you whip that. So whiplash is a mechanism. It is a mechanism. Sudden forcible hyperextension and flexion of the neck. You remember this. Patient, whenever they are wearing a belt or otherwise in a vehicle, sudden hyperextension, you break and flexion, it is a whiplash injury. That is a mechanism. But if you don't see any fracture dislocation in the X-ray, but there is a paralysis, then it is called as scivora. Understand?
Yes, sir.
Am I clear? Who was this talking?
Sir, Vandana.
Okay, good. Am I clear? So there in the same X-ray which was abnormal, that patient they have taken MRI. You see this white thing, there is only edema. This white thing is a cord edema. Look at the vertebra, everything is normal. So cord edema is there. That is the reason for your neurological deficit. Hence it was called, this is a whiplash injury, but if there are no X-ray abnormality, it becomes a scivora. Okay?
Yes, sir.
Okay. We'll go for this. Earliest reflex to reappear in the spinal shock. As I said, a patient comes with RTA or fall from height. There is a complete absence of superficial reflexes and deep tendon reflexes. Conscious patient and no movement. Okay. So he is in spinal shock. Okay. Now once he recovers from spinal shock, we will know whether it is a complete cord injury or a incomplete cord injury. You have to focus on each and every word. So how will you know whether if how will you know whether the patient has come out of spinal shock? So the first reflex which reappears after spinal shock is, if you had heard me clearly and carefully, you would be able to answer this, but I don't expect an answer from you people. So these are deep tendon reflex. They appear late. Abdominal reflex depends on the level of injury. If the spinal cord is injured at cervical level, even though the patient comes off spinal shock, the abdominal reflex will be absent. So the answer is bulbocavernous reflex. So if the bulbocavernous reflex is present, means the patient has come out of spinal shock. And it is now you have to assess whether it has incomplete. So bulbocavernous reflex is present, but there are no other reflexes at all. That means he has come out of spinal reflex. It can be complete or incomplete. So if there is a knee reflex present, knee reflex present, ankle reflex absent. So it can be incomplete. That means part of the spinal cord is still spared. Okay. So you know the answer now. The earliest reflex to reappear after the spinal shock is bulbocavernous reflex. A patient presents with a, please read carefully, normal Babinski reflex, ankle reflex absent, saddle anesthesia. Saddle anesthesia is, saddle is what? Saddle you sit on the horse. Perianal anesthesia, the part which comes in contact with the horse saddle. So that part is saddle anesthesia. So patient presents with normal Babinski, ankle absent, saddle anesthesia, and micturition means bladder is affected. Bladder is affected, saddle anesthesia is, what is the diagnosis? So very, very easy question. Don't be disappointed by the words what you are seeing. So these are ruled out. Cauda equina syndrome is the answer. So you know what is cauda equina? The end of the spinal cord. Cauda is what? Equina is, cauda is end, equina is horse. So cauda equina is horse tail. Horse tail. Okay, if there is an injury to the cauda equina, lowest part of the spinal cord, where then you see only the roots are there. Lowest part of the spinal cord is the cauda equina. So in cauda equina syndrome, you remember Babinski is present. So Babinski is normal means it is a lower motor neuron lesion. You would have read in medicine. LMN Babinski present, UMN Babinski absent. So cauda equina syndrome is LMN type of lesion in spinal fractures. Acute flaccid paralysis means flaccid paralysis is there. No reflexes. Complete paralysis of the limb. No reflexes. Loss of perianal reflexes means what? Bulbocavernous or anal scratch below the spinal cord of the injury is due to. Okay, please read this carefully. So there is a complete paralysis of the limb, no reflexes are there, loss of perianal reflexes. Okay, is due to. If you see by looking at the option only, you will know, even if you have not read, It is because of the spinal shock. Bulbocavernous, I had explained you. You can pinch the glands or pinch the clitoris depending upon the gender of the patient, or if the patient is catheterized, you have to pull the catheter out so that bulb inside the bladder is stimulates and you feel for the reflex in the anus by doing a PR. So there is a loss of perianal reflex, means patient is still in spinal shock. What is not true of atlantoaxial joint? You please remember this diagram. This is atlas, this is axis. Okay, not true about the atlantoaxial joint. Vertebral artery passes through foramen magnum, posterior to the foramen magnum. Is it correct? Now you should tell me, your first, second and third year anatomy is fresh. Anybody? Vertebral artery passes posterior to the foramen magnum. It goes into the foramen magnum, isn't it? This is wrong. Means atlantoaxial joint is ellipsoid. No, it is a pivot joint. Look at this. It is a pivot. You know what is pivot? You can balance your football on the index finger. That is pivot. So this is wrong. This is wrong. Atlanto-occipital joint have flexion extension. I told you, yes movement happens in, this is the skull. Yes movement happens in
Atlanto-occipital
joint. Atlanto-occipital joint. No movement happens in atlanto-axial joint. Even if you remember these things for today, I have achieved my objective. So posterior longitudinal ligament pass through the spinal canal. Is it correct? I drew the diagram, isn't it? So here is a posterior longitudinal ligament. Here is the anterior longitudinal ligament. So this is correct. The question is not true. Okay? Am I clear? Spinal injury with no radiological abnormality is commonly seen in. Yeah, you can answer this.
Children.
Okay, good. Because the ligaments are flexible. That is cure, I told you. Ligaments are flexible. Okay. Dennis gave how many column theory? I have explained you already. Dennis
3.
dash column theory. How many? Yes. Somebody tried.
So 3.
Yeah, very good. So please remember. In spinal shock, knee jerk is the first reflex to return. Is it correct?
No, sir.
Very good. High thoracic lesions are associated with severe neurodeficit. You wait. Go to the next choice. Failure of return of cord activity within 48 hours means he is not coming out of spinal shock. He or she is a poor prognostic sign. Yes, this is correct. This is also correct. The answer is 2 and 3. So one thing you please remember, high thoracic injury, the canal width is small in thorax, wide in the lumbar region. Okay, the spinal canal, inside there is a spinal cord. Here in lumbar there is enough space here. There is very little space. And in thoracic, the cord arrangement is very, very dense. There is very, very dense. In lumbar, they have already supplied to the upper limb and the chest and trunk. Now only the roots passing and supplying the lower limbs are remaining. So they are sparsely arranged in the cord, and there is a enough space in the canal. So remember, in thoracic spine fracture, the paraplegia is dense, paraplegia is complete. In lumbar spine fractures, paraplegia is most of the times incomplete. I told you. Okay, I think a kind of a repeat. Return of bulbo-cavernous reflex in spinal shock. Quickly go through this.
Sign of
Option 1, sir.
Yeah, sign of recovery from the spinal shock. Okay, good. Symmetric areflexia. Okay, bladder and bowel involved, and lower limb is seen. Please remember this, symmetrical. So one thing you remember, nerve root damage means one side it can be damaged, other side it need not be, so it is cancelled. Brown sequard is half of the portion of the body is involved. So suppose this is a cord, which is half of the spinal cord transaction. This is a Brown sequard syndrome. So that cannot be symmetrical, isn't it? One side it is affected, one side it is not affected. That is again asymmetrical. Now you are left with only chorda equina and conus medullaris. Conus medullaris is a spinal cord. Still it is a cord. Chorda equina means already it is a, remember conus medullaris is UMN, chorda equina is LMN. Always UMN is a symmetrical. Not always, in this case. I am taking in this case. So the answer is conus medullaris. Okay. A patient is diagnosed with disc prolapse, reveals paralysis of the extensor hallucis EHL. Which nerve is affected? Some things about disc I will explain. Okay. Intervertebral disc. So intervertebral disc, suppose this is L4, this is L5. There is an intervertebral disc which is prolapsed. Please remember, if there is a L4, L5 disc prolapse, it is the lower nerve which is affected. Means if there is L4, L5 disc prolapse, L5 root is affected. You never, this you remember for your rest of the life. We'll again dissect later if needed, but whenever you call L4, L5 disc, L5 is affected. L3, L4 means L4 is affected. L5, S1 means S1 is affected. S1 root, Okay. So EHL is extensor hallucis longus is paralyzed. Means L5 is paralyzed. L5 is paralyzed means L4, L5 disc is there. L4, L5 intervertebral disc, L5 is affected and it is reflected by weakness of EHL. I'll explain, I have one or two diagrams in subsequent slides. Okay. Okay. So I wanted to show you this diagram. You have to remember this again. If L4 root is affected, when L4 root is affected, L4 root is affected if there is a L3, L4 disc prolapse. So what happens if L4 root is affected? your quadriceps knee extension is absent. Remember this. So L4, L5 disc prolapse is there means L5 root is affected. So how do you detect clinically? The EHL is weak. Extensor hallucis longus tendon is weak. If there is L5 S1 disc prolapse, now that you are in second, third year, so you will get a chance to see MRIs of one of your relatives. You get to know that they are suffering. So take interest in whenever they forward in WhatsApp to seek opinion to show which doctors, that time you take interest, then only you will remember. So if there is a L5 S1 disc, S1 root is affected means ankle jerk is absent. Very simple markers. This is essential even if you become a neurosurgeon or orthopedic surgeon in practice, it becomes very essential. So as I was mentioning, there was a patient with IVDP. He had EHL weakness, extensor hallucis weakness. That means L5 is affected, means L4, L5 disc is involved. So interesting. So you will know by clinical examination only, you will know what will be there in the MRI. The root value of thumb and middle finger. Can anybody attempt answering this? The answer is C6 and 7. I cannot explain you, maybe, but you remember this, I will come in subsequent slides. Okay, this is one very important slide you should remember. Very easy. You sequentially 5, 6, 7, T1, 8 and T1. Okay, so see, shoulder C5, elbow C6, wrist C7, finger C8, intrinsic hands, intrinsic muscles, that is dab and pad, abductor interossei, that is palmar interossei and dorsal interossei, that is intrinsic, T1. So if you see problem with the shoulder abduction, you know C5 is involved, elbow flexion C6, wrist extension C7. If the finger there is a clumsiness, it is T1, and finger flexors, it is C8. Please remember, it is very sequential. From shoulder, it is brachial plexus basically, isn't it? C5 to T1, but you should know shoulder 5, 6, 7, 8 and T1. So L4, L5 disc prolapse compresses. Yeah, you can answer this, I guess.
L5.
Very good. Okay. Ankle reflex narrow root. I have explained you in the past.
S1.
S1, great. So this is again one, you remember this diagram. Maybe you want to see the video later also. It will be uploaded. You see that video. Okay. That was for upper limb. Now for the lower limb. See, from hip you go downwards from anterior to posterior. Okay. So L2, L3 hip, L4, L4, L3, L4, L4, L5. So please follow. If you don't follow this, you ask me. Okay. L2, L3 hip flexion. After 3 comes 3 and 4 knee extension, all anteriorly. After L4 comes L4, L5 ankle dorsiflexion. So sequentially you follow. L2, 3, 4. So 2, 3 hip flexion, 3, 4 knee extension, 4, 5 ankle dorsiflexion. Okay. Am I clear? These are very important. If you remember this, even it will be helpful in reading medicine, orthopedics, and answering some MCQs. Okay, write like this, then you will remember. So 2, 3, 3, 4, 4, 5 anteriorly. Hip flexion, knee extension, ankle dorsiflexion. Okay. So once you remember this, there is a overlap here. Anteriorly, there is a overlap. Overlap, I mean, see, okay, I will write again. Here I will write, that's better for you. See, L2, L3, hip flexion, knee extension, ankle dorsiflexion. So now you jump backwards for the same joint, opposite side. L2, L3. 4 and 5 is for extension. L3, L4 knee extension it was there. Hamstrings L5, S1. Ankle dorsiflexion was L4, L5. Now it becomes S1, S2. So opposite movements of the joint, no overlap. Next joint, there is a overlap. Can you remember like this? Anybody can, at least one of you should say yes. Mohan. Okay,
Sir.
anyway, will not waste much time, right? So, patient involved in road traffic accident presents with quadriparesis. I said all four limbs are involved. Sphincter means bowel and bladder sphincter disturbance is there. Sensory level is upper border of sternum. Respiratory rate is 35. Likely lesion. Okay, there are important points you have to pick up. So all the four limbs are affected. Means upper limb is also affected. Means C5 is affected. Okay, that means what? So C1, C2, if it was affected, he will not be breathing. See, all intercostals are affected and even your phrenic nerve is affected. So C1, C2 is not a possibility. Thoracic T1, T2, T3, T4 means from C5, C6, C7, C8. The upper limb should have been spared, isn't it? But they are affected because all the four limbs are affected. So the answer is C4, C5. 40-year-old male after road accident, spinal injury. His lower power is greater than the upper limb. Sacral sensations are present. Type of spinal cord lesion. So okay. So I was mentioning there are different type of spinal cord syndromes depending upon which part of the spinal cord is affected. So you this I will give answer, but you should go and read. The answer is central cord syndrome. So what you please remember, if this is your spinal cord, this is your gray matter, the spinal neural canal. There are arrangements of the different tracts, sensory tracts, motor tracts, and anterolateral pain tracts. See, if this central cord part is affected, this part is affected means what happens? The lower limbs are affected because lower limb nerves are in the center. As you go on, the nerve have to go on dividing. It is like a branch of the tree. So the peripherally it goes to upper limb, centrally it goes to the lower limb. Since here the spinal cord, which the upper limbs are less affected, lower limbs are more affected, means the central arrangement is more affected. That means central cord syndrome. Anterior cord, posterior cord, they are self-explanatory. I'll not explain there in this. Okay, this is what I wanted to show you. Okay, this is a spinal central cord syndrome. If this part of the spinal cord is affected, what will happen? extremities, upper affect extremities than lower. Anterior cord means complete motor dysfunction. If it is at C5, all the motor functions of upper and lower limbs are affected. C5, because the anterior part is having motor tracts. Brown-Sequard syndrome means the because of the decussation, you know that you should have read in a neuroanatomy, I will not go there. Loss of motor function on the same side, pain and temperature on the opposite side. You should know this because how the cords are arranged, how the tracts are arranged. The motor and the vibratory sensation on the same side, but pain and temperature on the opposite side is affected. True about the fractures of the vertebra, it can be more than one. So wedge compression causes by flexion injury, you don't know. Anterior longitudinal ligament runs along the posterior surface, definitely no. Vertical compression force doesn't involve the cervical spine injury, less common because it merely affects the thoracic vertebra. Chance fracture occurs in flexion distraction. Yes, it is correct. Fracture dislocation is common in flexion rotation injury. This is correct. So this is correct. Wedge compression causes in flexion injury is correct. Vertical compression doesn't involve. This is not correct. So this is in PGI generally there where multiple choices are correct answers. Which of the following is not true about the Jefferson's fracture? Okay, remember now? It is a burst fracture of ring of Atlas. I told you. This was a ring. This was an axis. So this is correct answer. What we are want to find out which is false or which is not true. It is the most common type of Atlas fracture. Correct. Fracture definition is clear in CT. Yes, correct. It is associated with injury elsewhere in spine in less than 25% of the cases. Okay, this is the answer. This is false. Most mobile segment of the vertebral column. Yeah, this anybody should be able to answer. Quick.
Cervical, sir.
Very good.
Cervical.
So cervical. Cervical, very good. See, thoracic, it allows only rotation. Cervical, both flexion, extension, lateral bending, and rotation. Lumbar is again as good as cervical, but cervical is allows the maximum motion of the maximum movement is allowed in the cervical vertebral column. Most dangerous type of odontoid fracture. You will not know this, but anyway, I will explain and answer this. This is a dense process. This is called as dense. Don't confuse for Dennis. Dennis is the name of the person. This is os dense. This is part of the bone. See again, it can be fractured at the tip. It can be fractured at the base. It can be fractured at the body. That's how it is called, classified as 1, 2, and 3. So now I will not go, I'll not, expect you to answer this, but please remember, if it was fractured at the base, here it is in hangman's fracture. That you remember. Don't try to answer this. Mechanism of injury underlying the burst fracture. Burst fracture, you remember, this is the vertebral column. So burst fracture means entire body is burst open. It is made into pieces. I have some diagrams. I will show this. So mechanism of underlying burst fracture is vertical compression. You remember this. This is different mechanism of injury. One somebody answered whiplash injury, isn't it? Whiplash is sudden extension and flexion. Similarly, this is whiplash. Whiplash, you don't see a burst fracture. Burst means it is completely compressed and it gets displaced into the spinal cord. Okay, this is what I wanted to remember. It will be great if you can remember this. See, flexion, where the load, how can flexion happen? Suddenly patient falls from the height and falls on the buttock. So it causes flexion. Extension means it can, like backward extension. What happens here? This fracture happens. We'll go one by one. So flexion, what happens? There is load in the body. It collapses like a brick, a soft brick or a soft whatever dough. It gets compressed. So flexion causes anterior wedge compression. Extension causes avulsion of this. These are called as teardrop fracture. Please remember these words. At least you remember words today. Whenever you go and read, you will recollect that you have heard somewhere in some class. Distraction. It is like pulling. If the spinal cord, if one person pulls the head and other pulls the leg, this is called as distraction. Means there is a fracture across like this. Flexion, distraction. Now the combination of flexion and distraction. Axial compression. This I was telling. This was flexion. This is axial compression. I told you this was a question in the previous slide. Axial compression causes the burst fracture. Which vertebra fracture is due to flexion injury? Yeah, anybody can answer this? Okay, C6, C7. I will explain this in subsequent slides. Undertaker's fracture. Okay, you only remember this. Undertaker's fracture means patient who is handling the dead body. It could be in the mortuary or it could be in pathology, post-mortem or in mortuary. So while handling the body after death, there can be one special fracture that is called as Undertaker's fracture. You have to remember this. Undertaker's fracture is a fracture post-mortem and not ante-mortem. So this is seen in spondylolisthesis of lower spine, C6, C7. Today you remember Undertaker's fracture is a post-mortem fracture. It is a spondylolisthesis means what? It is a slip. C6, C7. So if there is a separation of C6 and C7, it is an Undertaker's fracture. How this happens is, if the body is kept on the this is the neck. I am very poor in the diagram. They keep a huge block in the neck, under the neck, to extend the head. That times a C6, C7 fracture dislocation happens. That is called as Undertaker's fracture. You just remember this. Yeah, this was I was explaining. Look at this. Okay, some part is not seen. Yeah, basically it is here. This is a normal disc, this is a normal disc, this is a normal disc. Look at this. There is a disc which has become black and there is a separation. This is called as Undertaker's fracture. Just remember that. Clay shoveller's fracture. Clay is what? Clay, this is a shovel. What is used for shoveling or removing the sand or the clay. There is a special thing named as a clay shoveler fracture. Abrupt flexion of the neck with a contraction. Okay, please remember, clay shoveler's fracture happens in avulsion of a spinous process. C6 or C7. Avulsion of spinous process of C6 or C7 is a clay shovel fracture. Okay, yeah. Anyway, this I have explained. Clay shovel fracture is spinous process of lower cervical or upper thoracic. Cervical is more common than thoracic, upper thoracic. Clay shovel fracture. So, fracture of spinous process of vertebra, no. Fracture of mid thoracic, no. Spinous process of lower cervical and lower cervical, I think. Okay, type incomplete. But I remember this diagram whenever you are asked about the clay shoulder fracture. Lower cervical and upper thoracic spinous process fracture. Yeah, this one diagram you remember, seat belt injury, flexion distraction injury, seat belt injury. What it causes is there is a fracture here which extends into the posterior elements also. It is also called as jackknife, jackknife fracture. These words you should remember. These words you'll remember if you remember these slides. As simple as that. Okay. If patient is wearing seat belt, definitely he will be saved by avoiding sudden death or major grievous injury, but he can have a spinal fracture. Most commonly, jackknife fracture, a seat belt injury. Chance fracture is also again is a one of the type of seat belt injury. Please remember chance fracture. Don't remember, try to remember too many things. There is a separation of the vertebral column. If it's separated at the intervertebral disc, it is a soft tissue chance, bony chance fracture. If it is the split is in the bony elements. Yeah, this is again some diagrams: compression fracture, burst fracture, chance fracture. So burst is, as I told, vertical compression from top. Simple compression is in flexion. Chance fracture is in flexion, like a seat belt, flexion, distraction. Anterior there is a flexion, posteriorly there is a distraction. That is a chance fracture. Seat belt injury, yeah, you can answer this. Quick. I'm overshooting by
Chance
10
fracture.
minutes. Very good, very good. I hope people are not bored. I can wind up now. If you are already bored and tired, anybody can prompt me in between so that we can continue in the next class. Okay. So teardrop fracture, as I was mentioning, there are two types of teardrops. Don't try to remember entire diagram. Teardrop, it can be extension teardrop or a flexion teardrop. Just remember these words. Thank you. So we come to the end of this class. Okay, boys are still there. I thought you people have left. Yeah, Abhinav.